Hi, everyone, and welcome to another edition of What's Up, Doc. We have an incredible researcher out of the United Kingdom. It's Dr. Ankur Thapar. I hope I got that correct, consultant vascular surgeon, and he is working on a very important study in the UK, and he is here to talk about it because we have a brand new website. It's called PADtrials.org. We're slowly building it out. But thanks to the team over in the UK, all of the researchers over there contributing, all of their amazing research that they're working on right now, we have started building out that website, padtrials.org, with all of the big breakthrough trials that are happening in the UK. And Anchor is actually working on one I'm really excited about. It's called the Duster trial. Before we get to that, let's learn a little bit more about you and your passion for peripheral artery disease in particular. I mean, when it comes to vascular surgery, doctor, you could literally go in all kinds of different directions. Why PAD?
I love dogs, and people who have PAD who have dogs seem to do better. So I kind of got into PAD.
Take that. PAWS for pad, pause for pad. That is perfect. And you know what? They should have a dog because I don't know if you know that people who have a dog actually more likely to get out and walk more each day than if you don't have a dog. And walking is the best medicine for PAD. So I'm right there with you. So get a dog. That's the moral of the story.
100% agree.
And you have two that are right there with you.
I do. I've got a Blackie and a Goldie, both Labradors. But no, I got into PAD after my fellowship in Australia. So I went to a big high volume PAD unit, and it was amazing, really eye-opening to see the stuff that was going on. I guess if you're siloed in one or two countries, you might be thinking you're delivering really good cutting edge care, but actually the guys in Oz were about 10 years ahead of us. And it was fantastic to learn and great to bring a lot of stuff back as well.
Right. We work a lot with Dr. Ramon Varco and Dr. Shannon Thomas out of Sydney and the university there. And in fact, their research team ended up having breakthrough research when it came to the trial for Esprit, the dissolvable stent for below the knee, and all of their work with that. They led that trial globally. And so they ended up getting recognized by the Global PAD Association for all of their work. So it's a great place to have gotten your early start and to have gained your passion for PAD. What brought you then to the UK?
I'm originally a Brit, and I work for a fabulous chap in Adelaide called Phil Puckeridge, who's probably one of the best surgeons I've ever seen. Amazing pair of hands, great brain, and really compassionate guy. And I always was, it was a 1 year deal. I always was going to come back to the UK, and my wife's a doc as well, and so she got a job back here, and I knew I was going to come back, but hopefully brought a lot of the good stuff back from Oz with me.
And when you brought a lot of the advanced, cutting edge tools and techniques back to the UK, were you met with any resistance or were you met with excitement for all of the different new limb salvage options that might be available for PAD care?
Well, I think when I came back, I raised a few eyebrows in the first year or two. Who is this guy? How does he think he can come in and do this? And et cetera, et cetera. And obviously, there are colleagues that you need to take with you on the journey. And so, really, the main job, my main job in my role at my unit, is to train and disperse the knowledge that I have, and really to get the other guys involved in research. We're a massive center. We're 1.2 million people. That's 2.4 roughly million legs, and that's a lot of legs to look after. And so I need help. And so one of my other jobs is getting the other guys involved in the care of PAD patients and their legs, and making it a big focus of our unit, and turning our unit into a limb salvage unit. That means delivering everything on site for the patients before they go home as a package, in one go.
And so people know, because I know care is different across the UK and even for us here in the United States, it varies from door to door, clinic to clinic, city to city, state to state, et cetera, depending on the extent to which a doctor will go to try and save a limb. And I know I'm writing an article right now that talks about the fact that the evidence for treating PAD is not keeping up with the evolution of disease. Where it used to be, PAD was a larger vessel disease with a major risk factor of smoking. So you had your aorta, a little further down the iliacs, the common femoral superficial femoral arteries in your thigh, and possibly the knee. Now we're looking at, with the diabetes and chronic kidney disease epidemic, more of a bottoms up approach where it's more of a smaller vessel disease with patients presenting not with intermittent claudication, meaning when they walk, they get some cramps in their calf that when they rest, they end up feeling better and they can go and try walking again. These newer patients are presenting literally almost in CLI, critical limb ischemia, which is likened to cancer of the leg, where they're experiencing their first presentation is their wounds on their toe that won't heal, rest pain that wakes them up at night, those Charlie horses that wake them up at night. And the top part of their foot and their toes are what's cramping more than, let's say, their calf. And so there's a certain group of doctors that are specially trained in this new wave of care with these smaller vessels with wires and balloons, literally going clear into the pedal plantar loop, the artery loop in the foot, versus other doctors that say if you have below the knee disease, it's not worth treating. It'll only lead to a revolving door of procedures. So let's just cut it off. I don't know where your facility in Essex actually fits, and what your care guidelines are for these patients. And when you say limb salvage, to what extent do your doctors actually go to save a limb?
That's great. So I think that's kind of like three questions. So I'll start with like the first thing you said. My youngest patient is 29 that we've kept both legs on. She's a diabetic. She's a single mum. She's on dialysis. And when she walked in the door, with disease in her foot, and I had a reality check. I thought, wow, is this 2025? Can this happen in 2025? And it happens. And when you've got that really difficult combination of type 1 diabetes and kidney disease, things happen early. And so a lot of my guys are younger than me now. It's not, I see guys in the 30s, 40s who are, coming in with bad disease. So I totally agree with you. Diabetes has made our job much more difficult. Secondly, we've gone kind of past the whole I need to open an artery in your foot. So some of my patients don't even have arteries in their foot, yet I'm asked to try and do a second or third procedure to keep a leg on. So, some of the stuff that we brought back from Australia was venous arterialization. That's a procedure where we make a new pipe, but in a completely different fashion to how we would approach things normally. We use the venous system, like a low pressure system, and we turn the blood around in it to the foot. And so we've been lucky enough to do the first 6 cases in the UK, and I'm currently the NICE advisor for this procedure for superficial venous arterialization. And it's just one of the treatments evolving for kind of patients who historically would have had a major amputation.
That's incredible, because we just had a doctor, Dr. Michael Sia, who is a surgeon at UT Southwest in Dallas, Texas, who posted on LinkedIn a before and after picture from the deep vein arterialization for patients. It's where they hijack the vein in the calf, usually a lower calf. I believe some of them go a little bit higher, and they reroute blood flow into the foot using that vein, as he said. He's seen some incredible perfusion in these vessels, like a new development of vessels down there in the foot, not in the main arteries. The main arteries, they're dead, but literally a whole new life down there in the foot. And I'm curious if that's something that you're seeing as well. He seemed pretty shocked by how well perfused the foot was after a matter of time.
Yeah, so we did our first patient in 2020. So we're at year 5, and she still has the leg, and she still walks around on it. So it's the longest one in the literature. So the difficulty is when you have a great success with your first patient, you're always set up for failure later on. So it's not magic, but when it works for the younger patients, it's fantastic, and it's a new option for people who are willing to take the risks of the procedure. It's not without risk, but it's one of a couple of technologies coming along, like tibial transport, and there are a couple other things as well coming along. But what I would say as well, just to answer your sort of third point, is that uh, where we've developed in our journey. So just to give you an idea, when I went through training, let's say a decade ago, what I can remember, one of my bosses having a patient with CLTI and saying what we should do is wait for that leg to demarcate with gangrene and then do an amputation. And that was like an accepted way of managing CLTI patients. So I'm going to fast forward 10 years in the same unit. So we now work with a major UK charity called the Limbless Association. And we said to them, how do you feel about doing trials about preventing amputation? And they said, we'd never thought about it. No one's ever asked us. So I said, well, why don't we go in as partners? And so we set up a number of trials. I'll come and talk about Duster a bit later on. And we expanded our practice and proctored both our junior trainees and also some of my young and enthusiastic colleagues, where we're offering procedures which just didn't exist 5 years ago. Venous arterialization is one, but there are a whole host of other things that we offer: intravascular lithotripsy, CRAB, procedures for people who probably wouldn't have been able to treat 5 years ago. But also not just focusing on perfusion. A limb salvage center has to do things like treat bone infection. It has to cover wounds when there's no obvious skin cover option. And it also has to provide surveillance and support for people. And even in those difficult periods where they have to transition to a major amputation, it has to be able to provide psychological support for people and their families. So when I say a limb salvage center, I'm not talking about restoring flow to the foot. I'm talking about the whole package.
That is incredible. And I would love to get those additional studies to put on our padtrials.org, as well as the links to the websites where patients can end up learning more about them, and also be able to inform their doctors how they can help them sign up for some of those procedures to see if they're actually a fit for those procedures, if of course they're willing to travel. I would imagine they have to be willing to travel over to your area in order to participate.
Duster is open in 3 sites. It's open in London, it's open in Essex, and it's opening in Manchester. So we have some capture. And remember, Duster is it's a pilot. So by sort of 2 years' time, we'll know if this is going to be something we can roll out UK wide.
Okay, so let's go into the Duster trial, because it's and set it up a little bit in terms of um, the patient ends up having to have a procedure, right? And they don't, I don't know what the schedule is for ultrasounds, but supposedly there isn't an ultrasound that frequently. And so now what you're trying to do is you're trying to say, hey, you know what, should we do more ultrasounds versus fewer on these patients? And does it lead to better outcomes?
Yeah, so when I left the UK, remember we're a state-sponsored NHS system. We would maybe do a limb salvage, angio, or hybrid procedure. Hybrid procedure meaning we might clean out an artery at the same time as put a balloon in an artery. Um, Patients would possibly be seen in clinic maybe 6 weeks later. If they're lucky, they might have some form of early warning surveillance ultrasound scan, but many wouldn't. And we would generally go clinically on how the patient was going, whether their wounds were getting better, whether their pain was getting better, and and things like that, and whether we could feel a pulse, with our fingers. So when I went to Australia, they obviously are a different model of healthcare, and they would survey their patients 3 months, 6 months, 12 months, and then every year. And this was like a complete shock to me. And first of all, I thought, wow, they're overtreating their patients. But then when I kind of saw the catheter-based technologies being used as a redo, actually the patients got on with it okay. And I think as the technology evolved, it meant going back wasn't such a big option. Like, I'm not asking you to do another bypass on this patient. I'm just asking you to do a catheter-based procedure with the patient awake. So it kind of made sense to me. And so when I came back here, the European Society for Vascular Surgery had released a guideline, which pretty much everyone ignored, which said we should introduce a surveillance program for at least a year, but possibly longer after limb salvage, catheter-based therapy. And I thought, well, why don't we do the trial and find out if this is worth our UK National Health Service really investing in it? Or is it a burden? Is it a burden on patients? Is it a burden on the sonographers doing the scans? You know, does it lead to more procedures which are useful, or does it lead to more procedures which are unnecessary? And that's really what the trial is going to look at.
And I would imagine that many of these patients after a procedure, they get in the UK discharged after a procedure and back to their GP. And we always find that troubling because that's not the same here. And what we find is patients are less likely to be in compliance with critical lifestyle modifications and continued medication and walking as medicine, et cetera, if they're not seeing the vascular, if they're only seeing their GP. And I almost wonder if this could be something that could expand to studying before a procedure, preventing a procedure, and how continued follow up care versus discharge with a vascular surgeon versus continued care with a GP without any follow up could actually increase compliance and improve outcomes for these patients with PAD. Because the number one complaint I get from UK patients is, well, I've been diagnosed with PAD. And well, first, I mean, I have to wait 6 to 12 months in some cases to see a vascular surgeon. When I see a vascular surgeon, they say, oh, you don't need a procedure. We're discharging you back to your GP. And then if they have a problem, they have to literally go back through the process and go to their GP to get the referral to vascular surgery again. And meantime, they're sitting there on a daily basis worrying about every nuance, the burning in the foot one day, the tingling in the foot the other, maybe the toe goes numb at one point, and there's just no feeling of accountability, or should, for lack of a better term, of love. And so they're less likely to be compliant. And then they present, what, a year later in the emergency room, a toe step away from amputation because they haven't done anything over the past year.
Yeah, so the data is that 4 out of the 5 amputations that will follow will happen in the first year. That's why we focused on year one for Duster, because if we're going to get the most bang for our buck, it's going to be in the first year. So Duster looks at a year
Mhm.
after the limb salvage procedure, and it asks, is intensive surveillance going to help? And I totally agree. If we're investing in people and we're surveying them intensely, I tend to think most people will take that quite seriously. And they'll actually say, do you know what? I'll take my medication and I'll ask you if I'm unsure. Same with the smoking and the tobacco exposure. So, if we're really investing in people, I hope they're going to invest in themselves. It's a hope. But until we get the data from Duster, I can't say that it's worthwhile. I can't tell if it's worthwhile the UK government investing in intensive surveillance because we have no data on it. Um, we looked out there and we asked the UK vascular unit, so who has a surveillance program, and 75% of units just made it up surgeon by surgeon. So really, there's no policy out there. There's no guideline from the Vascular Society for Vascular Technology, which trains the sonographers to do the scans. There's no guideline. There's no guideline from the Vascular Society. So it's really an open playing field, and I think we need to do the trial and then see what happens. So that's what I'm trying to do, really.
Yeah, it's a great place to start. It's great to start there with the folks having the interventions, then following them afterwards, because it can be costly with that revolving door if you're not able to just have that strict surveillance and make sure what's going on with these patients in the year following. But I could see it actually, once you get the data, if it proves to be beneficial, then doing a study on the patients. Okay, you're diagnosed. And so we want to make sure that you maintain the surveillance by a vascular surgeon and have regular ultrasounds versus being discharged and allowing the disease to progress to the point where your only option is to go to the emergency room and get your leg cut off.
Yeah, 100%. That's the whole idea behind Duster. And and
Your dog's battling back there.
yeah, I think so. Um, and so the whole idea really behind Duster, it seems to be pretty acceptable. So we've recruited 28 patients so far, and I really have only had one no from a patient, and that was because the patient lived a long way away, and the transportation to get the ultrasound scans might have been difficult. And I do get that because patients with CLTI, they have difficulty walking. They have difficulty getting to appointments. It's a disabling condition, as we've seen from all the, from the quality of life scores and things like that, and the sort of independence levels of people. So transportation in rural areas, I mean, we've chosen Essex because we've got a big area, and it's a 2 hours drive from one side to the other. So people have concerns. If we're going to pick up things like that, it'll be in our area most likely. I think in London might be easier. Manchester is we'll see. They're sort of a mix, really.
And can you actually spell out the acronym? So what does Duster actually stand for?
Yeah, sure. So duplex ultrasound surveillance after endo revascularization. I think I said that right.
That's great. And so what are the facilities
Sorry,
again that oh, go ahead, Mike. Mike is one of our
I was just
UK PAD warriors.
so duplex ultrasound.
Surveillance trial after endo revascularization.
Thank you very much. Sorry about
Oh,
that.
that's all right. We have a nice a website on the Anglia Ruskin University. I'll send that to you later. Vascular trials, and it's got all the details on the trial there.
Wow,
That's great
thank
because
you.
after this, I'll add not only this video, once our amazing producer Josh gets it up and ready, I'll add the link to that. So we'll have a full explanation on the Duster trial actually on our padtrials.org website. And we'll have a link to your website as well so patients can find out more. But what are the facilities? I know you want to expand it UK wide, but what are the facilities that are currently participating? I assume that Dr. Nasir Ahmad over there in Manchester is involved.
Yes, exactly right. So our main staff are based at Imperial College. That's Professor Alan Davies, and as you said, at Manchester, Nasir and Stephen Rogers are our main PIs up at Manchester. And we've gone for big volume units, some rural, some urban, some kind of mixed. And what we're looking to see, every unit has a vascular laboratory, and at the moment it's mainly used for diagnostics. If we find there seems to be some benefit for surveillance, we'll obviously have to justify the cost of the extra guys we'll have to employ to do those scans. And but it would be a reasonably rapid translation. It's something that the facilities are there. We would have to hire more staff. And so to justify that, we would have to justify outcomes, i.e. leg saved.
I love that IE leg saved. So if a patient is in another area of the UK and they want to participate, what are the indications? What are the parameters? I would imagine, are they picked before they go into revascularization? If they have had revascularization, is there a time frame by which they can still apply? If they can get, I would assume they'd have to get to your area, at least in the meantime until it expands, or they have to have some sort of referral. Can you walk us through patients that maybe aren't in these areas, how they can actually participate or learn if they're the potential
Sure.
participant?
Sure. So we're in pilot phase for the first 2 years. And so we have three centres, London, Essex and Manchester. So patients, the way it works is that patients have 3 weeks to join after their revascularization. So that gives them time that if they're in a one of those three areas or an adjacent area and they wish to join, the best thing to do is just email me directly, and then we'll set them up with their local study contact, who can then take them on for surveillance at that centre if they wish to. They will obviously transfer to that centre then and be managed by that centre. So for some people, that's an unnecessary travel burden, and I totally get that. But it's something that we have already got patients from adjacent areas coming to our area to join Duster. So I think some people are quite happy to do that. It just depends on whether you can make the visits. And the
Oh,
visits are, yeah, the visits are 6 weeks, 6 months, 12 months. They're pretty easy.
they are, and it's literally worth it to potentially save your leg, to have a little bit more love, especially when I hear so many areas are strapped for staff and struggling to get patients in and with follow-ups, that if there's a study that someone could participate in where they can get that little extra love, then it's worth a little extra travel and participating in this just to for even just peace of mind, I would imagine. And that's why I think that this is so important. And
100%, 100%. I think it makes sense to most patients, and it's just the logistics of can they get to the extra ultrasound scans if they're in that group.
And we have Kathy that has a question about whether or not she's in Scotland. And right now, as you said, is it only in England? Are you looking to expand to some of the other regions, such as Scotland? Maybe picking up, Dr. Alec Vasey over in Glasgow as one of the participating doctors.
Yeah, so we're funded for 3 sites at the moment, and we've got to demonstrate that we can deliver the scans, that the scans will give us useful information, and that they matter to patients and clinicians, because we could do loads of scans, right? And it might not affect care in one iota. And so we've got to demonstrate that we are going and acting on those scans and re-intervening on those patients who are at risk. Once we jump that hurdle, and that's about 2 years, then we can open up nationally. But at the moment, it's the 3 sites.
Okay, that's fantastic to know. We really appreciate it. And we're hoping that through this, we can get more and more patients to be aware of this type of research that's going on, because I would imagine that there are a lot of doctors that are out there that are within, a rock's throw, to be able to have their patients participate in something like this, which would be incredibly beneficial. How many patients are you looking at? You said you have 28. Do you have a
So
set number?
yeah, so our recruitment target for the pilot is 70 patients, and
Okay, not that.
within the 3 catchment areas, we have about 5 million patients who are eligible. So I think it's a good start. It's a good start.
It's going to fill up quickly. I mean, I would imagine there are revascularizations every single day. Are there any other restricting parameters aside from just simply that within 3 weeks and that they've had a revascularization? Is it just endovascular, or it is endovascular? I mean, that's in the title, but I assume,
Yeah,
okay. So
yeah.
bypass is not included.
No, so you would be allowed a hybrid procedure if you've had a procedure to clean out the artery surgically and then a balloon down or something like that. And one of the I would say there are 2 types of patients who maybe might not do so well in Duster, or it might not be relevant to them. So one is they're really frail patients. Perhaps you've done the procedure and they're going back to a nursing home, and we are not expecting them to live very long, like maybe they're 95 plus. In that kind of age group, we'll offer them the trial, but sometimes it's just too much for them. And the idea of having another procedure, if something crops up on their ultrasound scan, they don't want to face that. It's just not something they would want. So that's something to bear in mind. The other group to bear in mind are perhaps the guys who we've done a great revascularization on, but they have very bad sepsis, foot deformity, or severe pain in the foot. Maybe they've got a Charcot foot from diabetes. And maybe for those guys, even that we've done a great revascularization, they might actually say, do you know what? I cannot live with this leg. And for those guys who are considering having a major amputation, then maybe that's not the trial for them.
You bring up such an important point that especially when it comes to these patients that do have small vessel disease, and particularly with diabetic patients, that they end up not only with the main arteries having issues, but also the smaller, the capillaries that end up having issues. So even if you restore the blood flow clear to the foot, it's just not getting from the main arteries beyond. And that's not general peripheral artery disease. That goes into the general, diabetic foot. And a lot of times A1C control is the only option for you, or you end up with amputation because you can't do anything with those tiny capillaries. Once they're done, they're done.
We've got a trial for that as well called Impact P.A.D.
Well. I
Yeah,
love
so
this.
I'll leave
So
you
tell
to
us
it.
about that.
So Impact is a first in human study. So we've now done 5 patients. So in Impact, what we do is, so we're quite good at looking at angios and saying we've done a great job, right? And patting ourselves on the back. What we're not good at is stuff we can't see. So stuff which is very small, like capillaries. So like you say, we could unblock all the big arteries and see a great angio, but we don't know almost nothing about things like the capillaries we can't see. So what Impact P.A.D. does is we use a device called a flow rate catheter. And so what happens is before and after your procedure, we measure the flow and foot resistance to see if we've improved that. And then we look at the outcome of the procedure at 6 weeks. So it's early stages with that one. But again, it's the kind of quality control that's going to help us to say that at the end of your procedure, do we expect that this is going to be a long-lasting procedure for you and you're going to do well? Or despite everything we've done, do we feel that your capillaries are so blocked that we can get blood down to your ankle, but perhaps not really down to the toes or the heel where you really need it, and maybe this is not going to be a long-term winner for you. So that's what Impact P.A.D's going to look at, but early days.
I love that. So at least it's going to measure it. It's not necessarily going to solve the problem, but it's going to start the process of saying, hey, you know what? Yes, this is a problem. And yes, we need a solution. And then the solution's going to hopefully, then be tested. Maybe there are other options that are being worked on right now. With your flow measurement, are you looking at pedal acceleration time, the PAT, or you have a different method?
We're looking at milliliters of blood per minute, which is the flow rate, and that uses a thermodilution, so it's temperature of saline down a catheter. And then the resistance of the foot is measured in Wood's units, so it's pretty much physics. It's just physics, yeah.
And Ryan is wondering about what is a target for the UK in terms of A1C, where you have a better chance having better blood flow and not leading to that diabetic foot issue we just talked about.
So all of my guys who are coming in for kind of footwork or major amputations have HbA1cs over 100, like pretty much all of them. That's not to say that some of my guys coming in for revascularization are really well controlled being 42 or less in the English units. So there's a whole variety, but I would say the infections really start to happen when your HbA1c starts rising towards 100 plus. Yeah, that's very, very, very difficult territory because it crosses boundaries into other specialties, into orthopedics, into microbiology and sepsis land, and that can be really difficult for a limb.
Fantastic. Any other questions from our amazing group of P.A.D. warriors out of the UK? We have quite a few that ended up showing up here internally. If you have any questions, you can unmute or you can go ahead and post them in chat. They've been coming through in chat, so I've been able to field them and just ask away. But if you do want to jump in really quickly before we let the doctor go back to his daily piggy saving of those piggies, are you actually in the lab? Are you performing? Are you just doing the research? Not just, but are you in?
No, so I do the
the lab?
procedures
You do them too.
yeah, I run the trial as well, yeah.
Wow. That's incredible. How many days a week are you in the cath lab?
So I am 2 days a week in the lab, and one day a week running the trial. But I got a lot of good helpers, so it's running pretty smoothly.
Fantastic. Well, we really appreciate you being here. Hopefully, if people want to sign up, go to padtrials.org, and we are going to have all the information where you can sign up for the DUSSER trial, the IMPACT trial, and hopefully you can let us know, Doctor, all the other trials that you have going on there at your center, and we will add them to our map and make sure that they are distributed throughout our network of PAD patients across the UK. So that's really important. I think we just had another question that came across, and I just need to pull that up. So let's see. Okay, so how do we get on the trials? That's from Tracy. So Tracy, go to padtrials.org, and for each of the trials that's listed, we have a little bit more information. We also have a website that you can connect with the research team that is doing the trial, and it's best if you are able to bring that information to your vascular specialist and have them work on helping to refer you. But as the doctor said, when it comes to the IMPACT trial or the DUSTER trial, we can provide his email as well, or you can email info at padhelp.org, and we're more than happy to connect you with the doctor at any point in time as well. So really excited. Thank you so much, doctor, for being here. We really appreciate you.
No problem. I'll just like as the last thing to say is that we do run another trial for you guys, looking at infected diabetic foot. So I know a lot of you guys may have experience with bone infection as a result of a diabetic foot ulcer. We're running study 2, looking at implantable antibiotics for you guys, and study 1 has been amazingly positive. So during the pandemic, we used to have a lot of patients with diabetic bone infection in the community with lines, and a nurse would be going around administering IVs. And so we felt that was a pretty unsafe practice. So we switched to implantable antibiotics at surgery. And then we looked at the results of both of those, and they're published. And we found that, first of all, it's much safer giving implantable antibiotics. They don't give side effects. They don't get into the bloodstream. They don't affect your kidneys. Number 2, they're at least as good, if not better. And so we're now funded to do study 2, looking at long-term outcomes of guys with diabetic foot bone infection.
Can you walk us through what that looks like? Because we deal with a lot of patients that end up, and we always say, well, if the blood flow can't get through, then the IV antibiotics can't get through either.
Yeah,
How
that's
does
exactly
the
right.
implantable? So
Okay,
can you talk
so
about how the implantable works?
yeah, sure. So a lot of guys will be familiar with a break in the skin with some exposed bone or tendon. That's called a diabetic foot ulcer. So often this will present and does present quite often as an emergency with kind of pus and infection and sometimes sepsis. So we often will take those guys to theatre, clean up the wounds, revascularize the wounds, take samples, and then we usually take the patient back like a week later for another look. And what we do at that second look is that we drill that bone, and the marrow cavity, which is infected, we drill that out with a 3mm drill. And I want you to imagine your Colgate toothpaste. I guess you have Colgate in the US?
Colgate, Crest, all of the
Perfect.
above.
So imagine you lace that with gentamicin or vancomycin at 90 times the concentration you can get into your bloodstream, and put that directly into the bone. So that's what we do. And so that means the patient doesn't have to have a line. They don't have to take oral antibiotics. They just go home the next day. So it's been a big, big game changer for us. So from a unit where we used to have about 20 patients with lines, with community nurses giving antibiotics, we've gone to 0 lines from the introduction of that, and 0 side effects. So it's really, really, really promising for us for diabetic feet. And all we need really now is to finish study 2, which is going to tell us at a year how we're doing. But study 1 definitely showed that it's safe, no safety concerns, seems to be working as well, or if not better. And study 2 will tell us out to a year how these guys are doing.
So are you talking about osteomyelitis? So if they have osteomyelitis, or is this a general an
Osteomyelitis.
osteomyelitis?
Yeah.
Because if you are here, I mean, if it's chronic, they don't tend to just cut off the toes or the foot or the leg, but osteomyelitis is serious. That's a bone infection, right? And
Yeah.
the only option for most patients is cutting off that infected part.
Yeah. So, you know, historically that was the treatment, wasn't it? It was to have an amputation. That was the treatment for osteomyelitis. And then I think
Yeah.
people tried, you know, cleaning up the wound and giving people a line and IV antibiotics for like 6 weeks. But I think we've now gone to the next generation of treatments, which are, first of all, safer, patient friendlier, and they seem to work at least as well. And we'll ultimately find out whether they're better. So I think that's sort of paradigm shift three. So it's a real problem. Like a lot of our patients, we do a good revascularization and they've got wounds, and those wounds have infection and they have bone infection. And without that, whatever revascularization you do, they're going to come back for something in the future. And what I'm trying to make that is as close to zero coming back as possible. So to give you an idea, we've got that rate of bone infection in the future. The baseline rate of that, if you treat that, is 22%. So, you know, 1 in 4, 1 in 5 of our patients would come back for a minor amputation. So we've halved that risk with implantables. So we look to see whether that can be kept out to a year, which I hope it will be.
Is this something that is isolated to the UK or to this trial? Has it been done before? Is it being done elsewhere? I've never heard of it. I've never had the option offered to any of our patients across the United States either.
So we did the first comparative study in the world in the United Kingdom, and that's published last year. And so it's been very well used in orthopedic practice because they get a lot of bone infection in joints and things like that. And we simply borrowed that technology, which is already used in our hospital for those kind of things. And we used it in bone infection in the foot. And we're lucky because actually not everyone believed in it. So not everyone changed. I changed, 1 or 2 of my colleagues changed, but we had quite a few guys who said, no, we're just going to stick to the old-fashioned treatment. So we had a great comparator arm. And so we followed those patients out to 6 months. And I mean, I'm pretty happy so far with the results. And study 2 looks at what happens longer term, and also with independent people looking at outcome, which is important. So not me, not my team, other people.
So if someone wants to participate, I would imagine we have so many patients who have diabetic foot wounds over in the UK. How can they get involved? How can they say to their doctor, hey, I want to participate in that trial? I would imagine, again, they have to be willing to travel, be able to get to Essex
So,
to transfer their treatment.
actually, this product is licensed definitely in the United Kingdom, and for treatment of bone infection. So it is a licensed treatment. It's just really, we didn't really know what happened with people with diabetic foot osteomyelitis, whether it was going to be safe to use it on them, and particularly the concern was, would it be safe to pull the antibiotics that you give either long-term orally or long-term IV? Was it safe to pull those? And it is safe to pull those. We have demonstrated that. There are no safety concerns. And we've stopped people getting hospital-related infections like Clostridium difficile. We stopped all the nausea, vomiting, and the side effects like the rashes. All of that's just gone. You don't get that. So
Is
it's very patient-friendly.
So how does the patient talk to their doctor about it if their doctor says you have osteomyelitis, there's no option for you, let's just cut off your limb? Can they say to that doctor, hey, I've heard about this particular product? How do they find it? Can you find a doctor that uses it? I mean, what does that discussion look like for these patients if they want to have another chance to save their limb?
Sure. It's very early days with this, and we've got a community that we train. We had our national training workshop on Monday, which consists of orthopedic surgeons, vascular surgeons, podiatric surgeons, because everyone's involved in the surgical care of these patients, and so we need to train multi-specialty. A lot of people use it, and so I would have a look at the Vascular Trials website, read the papers that we've written, and then it's ask your surgeons about it. A lot of, usually within a unit, there'll be one person that does offer this. It may not be the vascular surgeon, for example. It might be the orthopedic foot and ankle surgeon that offers it. But it is out there, and it is licensed for use. It's just that we've never really had the data to say, is this safe or effective? And that's some of the stuff we're trying to generate, because it seems like an absolute no-brainer.
So you have triggered a flurry of questions. If you have a few more minutes, I want to let Kathy has quite a few. So I wanted to see if Kathy wanted to just ask them on her own. Kathy, if you want to unmute, you have a few great questions here that you might want to just run through.
Hi, I'm just really interested in this because this is obviously offering a lot of hope and saving money for the NHS. But I'm just slightly concerned that a lot of people will lose a foot while we wait for this to become more commonly used. But people would like to feel that there was an opportunity for them to at least get this considered. And so they would need to have some notion of the availability of this. I mean, I'm wondering for a start, is when you said your national training day, is that only NHS England? Or is it the UK that attend? Number one. And number two, obviously there are big hospitals in Scotland. People regularly do travel, and much of NHS Scotland does refer people to centres in cities. So it's not unusual. I see a vascular surgeon in Glasgow, and I live in Highland. There's no vascular in Highland anymore. I'd have to go to Aberdeen, Dundee, or Glasgow, so I'm travelling anyway. Husband travels for cancer treatment to Glasgow, and it's common to do this. So travel isn't really the issue. The issue is, how would you go about if you found yourself, I'm not in that situation, thankfully, but I'm just thinking of all the other patients that are. How would you go about this if you found yourself in a situation of having a sort of bone infection, potentially losing a foot? What could people do practically to try and raise awareness that this option might be possible, even if it was the orthopedic surgeon that did it?
So what I would do is I would print off the paper, and then if you have bone infection, I would say, does your center offer something like this? And I think you're right. It might well be the orthopedic guys. They're much more familiar with it than us vascular guys. So our workshop at Monday was actually aimed at training UK vascular guys, and it was nationwide. In fact, there were a couple of guys from abroad who were interested as well.
Right.
Because it's straightforward. Like, I mean, if you can train me to do it, it must be pretty easy, because I'm not good at orthopedics. Like you say, it's much cheaper than putting in a line and paying a nurse to go to your house every day, especially if you're going back to theatre anyway to check on the wound in a few days' time. Just implant it at the same time. It's you don't have an extra trip to theatre. So yeah, I would. It's early days with this one. People want to see the data for this. So really, my job is to get that independent 1-year data, and I've put the 6-month data out already, just so that people can understand that there are no safety concerns that I've seen so far. I haven't had, and it's not that like that I've invented the product. The product has been around for about 10 years. So there's a huge global safety network out there. So I'm, we're just using it in a different way, in a different patient population, who have historically had a bad time, I think, with bone infection.
Yeah, I think
And we
it's a
have,
game changer. Thanks for that. Yeah.
yeah, that was a real surprise. I want to get this. So we need to connect, especially after this, so that I can get a list of these trials and be able to get the information up on our website. So we have the latest distributed to all of the patients in the UK on this. This is huge. And we have Ryan that wants to ask a question. Ryan, unmute and ask your question as well.
Hi, Doctor. Hopefully you can hear me. What
Absolutely
in
fine.
terms of the efficacy between the different antibiotic routes? So obviously you discuss implantation. My father, he's passed away now from P.A.D, but my mother has P.A.D, so you could tell I'm on edge for what could be. But my father had oral antibiotics for osteomyelitis. He lost his foot. But I'm just wondering, obviously, with the implantation operations that you've discussed now, what's the success rate in terms of how much do we have between the different routes in terms of success rates?
Okay.
As it stands.
So as it stands, at about the 6-month mark, if you take the tablet or IV antibiotics for 6 weeks, you have a 22% chance of that infection coming back in the same place. So about 1 in 4, 1 in 5 people will come back with an infection that basically you haven't treated the problem. Yeah. So, but it does work, obviously, in the other proportion of people. With the implantables, the rate of that coming back in the same place is 11%. It's half. Yeah. So, so we haven't seen, and that's without giving people long-term antibiotics either through a line or tablets. Some people have some skin infection, and so we allowed a week of tablet antibiotics for the skin infection, because you don't obviously treat the skin when you implant antibiotics into bone. So we allowed for that, and that's just at the operator's discretion. So yeah, that's roughly where we are at the 6-month mark in our center. But the main thing is that for patients is they have their life back. They don't have to wait for the nurse to come around. They don't have to worry about side effects or blood levels, and it's useful for us because it takes the burden off our community nurses as well.
Yeah, it helps everyone generally. Yeah, I can imagine the patients would feel a lot more safer. Because anything too long just makes people worry a lot more, doesn't it, I suppose. So thank you very much for that.
You want to hear about next year's trial?
Heck, keep going.
Great. Okay. So
let's keep going. I'm excited. This is giving so much hope to so many people. And after you're done with that, we have a couple of people, P.A.D and Mike here, that, have had some concerns about just having hope in future care. And I would imagine that this conversation is making a huge difference for them and all of the other people in the UK that are suffering from P.A.D and haven't been heard or have felt like, oh my gosh, am I just destined to lose my leg? This is giving them hope that they may never have to lose their leg, with so many great new options being tested right now.
So first of all, I think it's great you've got a patient representative with P.A.D called P.A.D. That's brilliant. Secondly, what I would say is that we're not, like I said, a limb salvage unit is not just here for the patients who have successful revascularization. It's here for the people who are going to lose legs as well, and it's going to mean a good quality amputation which you can walk on, and you have the minimum phantom pain from, and that is really a big, and you're supported. So that's the other side of the coin in our service. So we will try and keep your leg on to the point it's useful, but when it stops becoming useful, we'll give you a high quality amputation you can walk on and function on. And so in our center, that's meant introducing through knee amputation and looking at that, and that's been really, really successful for us to avoid above knee amputation. So next year's trial, may I do a quick poll of hands who has had a negative pressure dressing, a VAC suction dressing? Has anyone had one of those?
I don't think in this group.
Okay, fine. So
but we have had a number.
Yeah, so for a lot of people who have had particularly either ulcers, lower limb diabetic foot wounds, they would have had maybe a cleanup surgery, maybe a revascularization, but that wound is not closable. There's no skin to cover that wound. And so in that group, people have had typically like a suction dressing put on for months and months and months. And it's a bit like it's a sponge with like a cling film over it on your foot, with a pipe going up to what would be like the same size as an old Sony Discman, which you carry around. And you carry around for months and months, and we've always thought that that was the way. So about a month ago, a big trial came out showing that the use of VAC dressings in our practice had absolutely no effect on the wound healing, like absolutely no effect. So we all took a step back and did a big scratch head. So we talked to the guys who had VAC dressings, and we're still talking to them to understand what they liked and what they didn't like. What they liked was not looking down and seeing their anatomy. They liked something covered. What they didn't like was the fact they needed to charge this little pump, that it might lose the vacuum seal and it might start beeping. They might have to call a nurse. And a few of them tripped over the pipe which is obviously not great if you've got mobility problems. So we look to our colleagues in burns who have big problems covering wounds because there's not enough skin. And so the guys in burns, and particularly the guys when I was working in Australia, had come up with an artificial skin. It's not quite the outer layer, it's the bit in between. And the great thing about the bit in between, the dermis, is that we can put it straight onto bone. As long as there is some vascularized tissue, some foot muscle around, it will take. And interestingly, it will take over the implantable antibiotics, which has been a good, useful bit of information to find at this stage. So instead of the VAT dressings, we've done our initial pilot study looking at using this artificial skin to cover the wounds before people leave hospital, instead of using the VAT dressings. And it seems to work at least as well. It's much, much cheaper. And when you look down, you don't see your own anatomy. You're covered. You leave hospital intact. There is no open wound, and you're looking at part of your foot. You're closed. And people, I think, really appreciated that. So again, it's early stages, but what we're looking for next year is to really go in with industry and look at this product in a big population with lower limb wounds, not just foot wounds. There could be groin or leg or calf wounds, but to see what the results of this product are in our area with multiple different operators, and to look at what the times to healing are. And that should be a nice simple trial, which most of the follow-up will hopefully be done by telephone. So, a nice easy trial, hopefully, which we can get some useful data from, and also see if this is going to change the outcomes for people who've got lower limb ulcers, which we can't cover at the moment, but we have other options for now.
And so is this just being done at Essex, or is this a multi-center trial?
So it's both. It's a multi-center trial within Essex. So we also buddy with Cambridge, and we have a number of podiatric surgeons who work in the community who are also trained to use this kind of product. It's very, very straightforward. I mean, if you can teach me it, it must be easy. It's pretty easy. So we're looking to do a multi-centers trial, looking at how long the wounds take to heal, whether this kind of product, whether it takes well, what people's quality of life is, what their independence levels are, and also interview some of the people who are having it to see what their experience was of it. And so hopefully going from there. So that's kind of next year's work that we're setting up at the moment.
Oh my goodness, that's incredible. Yeah, I would love to add that to the site as well, because if patients are dealing with this, they may be able to transfer their care over there to have this as a potentially a different option, versus the wound vac. And Patty, do you want to jump in and unmute? I'm trying to read what you say here in chat. Oh, she actually just got discharged again today from a vascular I have not gotten the MRI scans from 8 months ago, but it can apply to see them. So she's just commenting. This is also just giving, patients hope for the future as well. And also Mike, we had Mike on. Mike is appearing in this week's innovation show that we have, where we have our Save My Piggies patient testimonial series, which we should get some of you and your maybe a patient or two on with some of these trials to talk about their stories, but then what you're doing and how participating in the trial has changed their life and what's happening now, et cetera, et cetera. So that would be cool. But Mike, this is giving you hope. Yesterday you were saying, I don't know about these things. I don't want to lose my leg like my mom.
Yeah, this is crazy. I'm really thankful for this, and thank you so much, Dr. Thapar. Just to find out all these new things that are coming in the UK is absolutely amazing. Yeah, it's kind of mind-blowing, really. So thank you.
Oh, thanks, Mike. It's I always find people incredibly appreciative of this kind of stuff, and a lot of this stuff is down to technology. So we're trying to get that technology which existed maybe in other countries, translate it here, evaluate it, and make it work for you guys. So really, that's what the job of a clinical academic in vascular is today.
Yeah, and I'm originally from Manchester as well, so it's good to know that the doctors in Manchester are going to be up to date with everything as well.
That's right. Actually, they're very, very good collaborators with ours. So they offer pretty much the same kind of stuff we do. So you got a big, good, big, busy unit up there.
Yeah, yeah.
Yeah, we have both Tracy and Mike that have worked with Dr. Nasir Ahmad, and as I said, he was had our limb salvage center of excellence for 2024. So we've worked with him a lot. He's pretty amazing. And I now understand what P.A.D has written here. So she got discharged today, and we talked about the issue that these patients are having and the psychological impact of being discharged, yet the feeling of suffering from P.A.D and trying to get over the emotional roller coaster and the physical roller coaster that comes with it, that I still think that a lot of doctors don't understand. Even in the intermittent claudication stage, so many doctors say, we're not going to touch you, don't come back until you have, and we actually have had this in the group where patients have said, doctors have told the patients in the UK not to come back until they have gangrene. And we had
Wow.
2 patients literally in the past 2 weeks that have posted that in our group saying they just don't understand. And so what P.A.D's saying here is she's like, okay, well, if I hadn't been in this group in our network and watching this video, that maybe the discharge would have had that emotional impact and that cascade emotionally. But because she's here and she's seeing there's hope,
Hi, Kim, it's
she's
P.A.D.
now.
It's me. It's P.A.D.
Hi,
Not
P.A.D.
she.
I'm so sorry. Yeah, I don't know
Yeah,
why
yeah.
do you know why I always say that is because P.A.D, P.A.D.D.Y is our mascot, our little
Yes,
art
exactly. I
person,
quite appreciate
and
that.
P.A.D is a she.
No, it just happened today that I'd waited 8 months before I got a telephone conversation with the vascular, who I hadn't really met at York, and I was kind of really looking forward to the imaging because I found that would really help me to understand what's going on. And I got a very terse letter from them saying they'd looked at it and they can see oculars, my veins are fine, but they can see quite a lot of spread of disease below the knee and some above. But when I said I'd really like to see the imaging, she kind of said, oh, well, I can't do that unless I apply and I've got to send my passport to the hospital to see the MRI scan. I did that after the meeting. But it was very sort of perfunctory that because I was too old, she said, for any further surgery, there was a sort of recommendation that a bypass might be relevant, but that I'm probably too old. So it was a kind of very dismissive process. But because of the information that I've got from you guys, I'm kind of on my own. I'm on my, I've got agency myself to walk through this until something really worse happens and I start getting rest pain or something. I mean, I was the guy that when I first went to my GP, they said it was impossible for me to have P.A.D because none of my toes were black. I mean, that was 3 years ago. And I've been trying to just get imaging so that I can see what's going on. And the vascular surgeon that was head of the York Hospital said that because they weren't considering surgery, imaging was out of the question.
Yeah,
Because
we hear this all the time. It's very backwards. It's not what we experience here.
yes,
We have a lot of
yes.
patients that can't even get the imaging for P.A.D. They're getting brushed off. And so
Yeah,
would
well,
love to get some of
that's
these
where it
collected. And
was. I mean, the only
yeah,
useful thing that I got out of the whole process was I paid privately for the same consultant at the same hospital, and he was a very nice man at that private thing, and he gave to my GP a very thorough report because I'd gone through the NHS. When I went back to the NHS, he knew it was me. So he didn't see me. He sent an intern to just go through that nothing had happened since my private referral, which I thought was a bit cheeky. Anyway, we got over that. And then because I'd had a permanent calf pain, I went back through a podiatrist. I went to a podiatrist, said, I've got this permanent pain. And the podiatrist said to my GP, who then went back to vascular. And then it took a year and a half to go from the GP to ultrasound test, who recommended an MRI, which I had November last year, and I got the report back from that in July, 8 months later, and she said there's nothing worth coming back for, that surgery's not in line, and that I'm open to come back if I go through my GP once again.
But that's if you have black toes.
Yeah, something like that.
And that's what Kathy just said as well, is, you sit there and you wait. But we hear this all the time.
Yeah.
It would be great if there was just some guidance for these doctors, who are treating P.A.D., whether GP or vascular, to maybe have a better script in terms of handling the situation and being able to. And I know that there is some research being done in different areas of the UK, where you have Dr. Thanos Saratzis, who's working on, well, what is post-procedure care, but is anyone kind of doing the management? I know Nasir Ahmad is working on possibly some research on remote walking systems, for P.A.D., but I think it's just maybe someone focusing on a better script, with saying, okay, you've been diagnosed with P.A.D. Let's check this box. Are you an intermittent claudicant, or are you already in CLI with this bottoms up disease? Doesn't matter if you have gangrene, or are you a toe stub away from amputation with rest pain that's waking you up, right? And then what are the checklists? Do you talk about getting advanced blood work to see if you have a clotting issue? Get transferred to hematology. Do you need to stop smoking? Do you need to be in a smoking cessation program? Do you need to walk? Okay, let's talk about walking. Do you need to change your diet? Do you need a referral to a dietitian or a nutritionist or a special program for diabetes? I think that would be a really great study to develop that script. And that's something that with the Global P.A.D. Association, we would love to get all of our patients involved and work with you and your team on that.
Yeah, so we've done a trial like that called Reset 2, which we've published just now. And so Reset 2 looks at patients with a remote treatment for claudication. And so it uses one of these. And so we gave patients an app. And in one group, they used the app to track their walking. In the other group, they got a physiotherapist to do video calls with them and set them bespoke exercises and targets, but they still use the app to log the walk. So we know how far they walk. And I'm going to ask you guys what you think happened in the trial.
Kathy?
Which group did better? So the physio group or the do-it-yourself group? With both of them, they had the app just to log how far they're walking, right? So an app like Strava, for example.
Mike, what do you think?
I would love to say the app, but I think it's probably the physio group.
No,
I would love
I'm
to say the
different
app,
on that.
because for me it would be the app.
I think it's people that did it on their own.
I think it's the walking
Well,
group.
we don't know about people that did it on their own. They're not in the group. I'm doing it on my own. I'm not in the group.
But,
This is a choice.
I could see that someone with accountability. It's interesting because here in the United States, if you look at our supervised exercise therapy program, where it's either remote or it's in person, where they actually go and they meet with someone twice a week, 36 sessions, right? Only 5 in the studies, they do better. But when it's not in a study, only 5% of Medicare people enrolled in Medicare that are enrolled in these supervised exercise therapy programs actually finish the 36 sessions. That people in independent ones are actually more successful because the programs are more flexible. So But I'm curious there because both seem to be remote and having to be on, just the phone versus no one on the phone. Still a schedule. I'm wondering, so which one did better? Who's right?
Okay, so there was very little difference between the two groups. So the guys
Interesting.
at 6 months, the guys who just had a log, they walked about 300 meters. The guys who had the log and the physio, so an app and the physio, they did about 350 meters. So there's about a 50-meter difference, which is not hugely different on average, right?
Mm.
So what we showed is that the app, which is free, as long as you have a smartphone, and if you didn't have a smartphone, you could write it down and have a stopwatch. That was the alternative for people. As long as you logged that, and we checked that at 3 months and 6 months, basically you did about the same. And so you can interpret that how you want, like whether you should invest in a physio or not, just invest more in apps. But that's really something I think that'll change a lot in the next 10 years.
Well, that's something I
I
would
think
love
it
to
could
even have you
change
check
now.
out.
10
Our
years, 10 years. I've been 20 years with this and had to make it up as I go along. 10 years for an app to tell people to walk. Sorry. It's
But
just
we do have
frustration.
the Global P.A.D. Association. So we developed just a very basic app and we have found with nearly 600 patients that we have enrolled that patients are actually more accountable once they have the app, but also we tend to see is that the patients who are not just doing it independently, but know that their doctors have access to the walking data, that is what we found is actually key to the walking, is that when they go to their appointment, no matter when it is, that the doctor can access that walking data and use that as a jumping off point for the conversation. And so our app measures strictly claudication time and time to rest, as well as, just total time rest and walking. But for the most part, I mean, that's all ours is as well. But then we have a dashboard that we give to the doctors, and it's all at no cost as well. We have doctors in Spain using it and Australia using it as well. One in Canada. The majority are in the US, but as I said, it's at no cost. Would love to see even a study on that to see if there's, something, with that maybe just the accountability. I mean, you don't need these supervised exercise therapy programs, which are supposed to be gold standard. You don't need it. You just need that much direction, clear direction, and accountability. And then what we also do is we have community support like this. So every Wednesday we have experts that come on and answer questions about walking. And then we have a community support group where people are posting their milestones and right, Kathy, and cheer each other on. And we give, I think, the most explicit directions out of anyone that's out there in terms of how to walk effectively to grow those collateral vessels. And in fact, we're writing a book on it as well, taking the whole approach, educating people on P.A.D, but taking the approach of it's a how to walk handbook that we're stemming everything else off of to really promote that idea of this is what you can do. You can walk, you can grow your collateral vessels, and empowering them with the right information when the doctors don't have the time. Or we find Dr. I've actually had doctors tell me that they didn't realize that there was a way in which you needed to walk in order to grow the collateral. So what they were telling the patients, and what I find the majority of doctors do, bless their hearts, you don't know what you don't know, is they were telling patients, oh, just get out and walk for 30 to 60 minutes a day, and if you need to rest, you need to rest. But it's not just the casual walking. It's not just, and there's a big focus with a lot of these, just get up 15,000 steps a day. It's not about the steps. It's about that regimented program where you are literally taking time and focusing on pushing through that claudication. And this is mainly for the intermittent claudicants, right? You push through, and that's where you are triggering the collateral network of vessels and also training your muscles to work more effectively with less, right?
That's the right word. So I think the right word is training. It's not walking, it's training. Like you train for a marathon, you're training exactly the same way, but for shorter distances. And you hit the nail on the head. You wouldn't train for a marathon without looking at your workout times, your distances, and the same for you guys when you're training for intermittent claudication. And someone needs to look at those and also coach you. Whether that should be a physio or whether an app can do that with your doctor, I think we've shown that it's roughly about the same. But also it's the buy-in from people that they're getting looked after and that they should then look after themselves. Because if you, at 6 months, let's say you don't win with the walking, you get worse, then at least you're in as good a shape as you can to have a procedure as well. So it works for everyone.
I love the way you phrase it. That's a great way to end this session. You have generously donated so much of your time above and beyond. We really appreciate you. I think we could, talk to you forever. Would love to have you back again, to answer more questions, to have greater discussions, because this has been, I think, one of the most valuable sessions that we have ever had on our network in nearly 6 years. I mean, this has been absolutely incredible. And we appreciate you so much. And we look forward to getting more information on those trials so we can get them up for people at padtrials.org. Also, if you have questions, you can email me at info@padhelp.org, and I can get you in direct contact with the doctor as well and give you more information on the trials. But thank you, everyone, for joining us. We really appreciate you.